Welcome everyone. This is Dr. Sharad Jaitly from New York. Thank you for watching, learning, and sharing on MuniMeterHealth.com, your favorite website, which is dedicated to teaching you and educating you on human heart and its illnesses. So once again, welcome to MuniMeterHealth.com on Facebook and on YouTube. Those are our two channels, as you know. Hope you're following either of them or perhaps both of them. Thank you for your enthusiastic growing interest and support in my cause of spreading this education freely to all, not only to my medical fraternity, but also to the general masses, because my goal is to educate the patients and the families, and of course, the medical fraternity as well. So without any further ado, let's delve into the state of the matter, as I always say, and that is the matter of the heart. And today we are going to be discussing VSD, ventricular septal defect. What is ventricular septal defect? Now, these are congenital anomalies. I'm sure people have heard about a hole in the heart, for instance, and obviously a child was born with a hole in the heart. And as the child grows, many times these so-called quote-unquote holes will obliterate or will eventually disappear. They'll spontaneously close, if you will. And so the defects are not even existing by the time the child arrives into the adult practice. So, but many times when they do arrive, even then they may be insignificant. So nothing greatly to be excited or worried about, but the fact is that one should be aware what ventricular septal defects are. And that's mainly for the general public that I was just making a mention about. So without any further ado, let's understand how many VSDs or what kinds of VSDs exist. There are four varieties. One, obviously, there is one which is an inlet variety, there is an outlet variety, and there is a membranous type of, which is a perimembranous type of ventricular septal defect, and then there is a muscular variety. Now, muscular variety can exist in the entire, now let's draw my sketch of the heart, if you will, and as I draw, I'll probably show you exactly how it looks like. For instance, if this is your right side of the heart, and this is becomes your left side of the heart, I'm showing it slightly bigger, obviously, than the right side. Again, these are artistic way of showing, in my sense of artistic way of showing the heart. So this way it becomes a little more simpler for us to follow. So these are the two outflow tracts: the pulmonary artery on the right side, and this is aorta on the left side. The tricuspid valve on the right side and the mitral valve on the left side here. This is right atrium, right ventricle, left atrium, left ventricle. So the basal portion of the septum, if you will, is all perimembranous. So this is where this portion of septum may show a defect. If there is a defect present here, that'll be perimembranous in this area. Muscular obviously will be somewhere here, more towards the apical portion of the heart. Okay, so this is all muscular. This whole area is muscular. Now, there is an inlet variety which is normally present right next to the aortic valve and the tricuspid valve. So somewhere here, it could be the inlet variety. And then the outlet variety is, which is the other name for it, is subpulmonic, if you will. It's that the name suggests itself that it is subpulmonic. That means right below the pulmonary valve, so somewhere here. So this is where the fourth variety is. So you have an inlet, an outlet variety, the perimembranous variety, and then the muscular variety. Now, just remember that muscular variety can be multiple small little fenestrations throughout the muscular portion of the septum, and invariably they close as the child grows into adulthood and later life. Perimembranous is the most common variety. Remember that. This is the most common variety. 80% of these defects of VSDs, they are of perimembranous variety, and they are right in this region. Now, they could be very small, and therefore they can produce a loud heart murmur. Because remember, the left ventricle is very powerful compared to the right ventricle, and sends the left to right shunt across through these small defects. So the smaller the defect, the louder will be the holosystolic murmur. It will be systolic. Why? Because the left ventricle is sending blood during systole, trying to send it through to the aorta, but then there is a defect, and therefore through that defect the blood traverses across, and it's called the left to right shunt and comes to the right ventricle. As a result, there is increased pulmonary flow because more blood is now coming into the pulmonary circuit and eventually coming back into the left ventricle again to pump. So the left ventricle is working hard anyway. Now the right ventricle starts working hard because you have increased pulmonary flow. So just remember that. And therefore, one sees an RVH pattern on an ECG very early on. So even before the heart failure sets in, one starts seeing the right ventricular heart failure, right ventricular hypertrophy rather, if you will. Now here I'm moving my screen a little bit, so pardon me on that. But anyway, so that's where we are. Now the echocardiographic features clearly show the defects. It's almost a wonderful test. It's a very, very important. The entire germane of diagnosis is dependent on an echocardiographic criteria. So one can define the size of the defect, the location of the defect, and the types of defects, and the number of defects, etc., via an echo. You very rarely have to do a cardiac MR to really ascertain the size, the defect, and the number and the location of the defects, etc. But otherwise, normally the transthoracic echocardiography is the diagnostic procedure of choice for VSDs, because you can also calculate the number of shunts, the amount of shunt, etc. And of course, it corroborates well with the murmurs. Now remember, a lot of this blood that's coming back to the left atrium to left ventricle, the hemodynamics are such that the mitral flow is also increased. So that gives you a diastolic rumble, like a mitral stenosis type of murmur. So what are the two murmurs that you're going to hear? One obviously is the left to right shunt, which is present. And the other murmur that you're going to hear is the mitral flow murmur, and which is almost like a mitral stenosis differential, if you will, because there's an increased flow across the mitral flow, across the mitral valves, and that results into mitral flow. So left to right shunt, which gives you a systolic murmur, and a mitral flow, which gives you a diastolic murmur. So these are the two heart murmurs one will hear, and of course you'll see the shunts and the increased flow as well. Now, once the left to right shunt starts reversing, because eventually what will happen is if you leave the shunt, if you leave the shunt unattended, what the usual progress is the right ventricle will start to hypertrophy until the left ventricle fails. And when the left ventricle fails or starts diminishing, the right ventricle will take over, and the shunt will now appear to go from right to left. So originally, as you see, the shunt was left to right. Now it is starting to reverse and it goes back from right to left. When it goes back from right to left, that's when it's called Eisenmenger Syndrome. It's a reversal of left to right going to right to left shunt, and that's called Eisenmenger Syndrome, if you will. And that Eisenmenger Syndrome is basically a cyanotic condition in a setting of VSDs where the shunt has reversed from left to right to the right to left direction, and as a result one has more deoxygenated blood now going into the systemic circulation, if you will. And these are the inoperable cases, so you want to avoid seeing this problem. Once the Eisenmenger syndrome sets in, then of course there is no sense in closing the defect, because then it's just a management of right ventricular failure, and things are not as good at that point. So yeah, the whole idea is wanting to see if you can actually catch the defect and close the defect rather before the shunt actually reverses from left to right to the right to left. Okay. So as I said, there is a holosystolic murmur, which is the left to right shunt, and of course the increased mitral flow will give you a differential of a mitral diastolic rumble, almost akin to the mitral stenosis murmur here. We've discussed the ECG and echoes, and the defects need to be closed. So just another way of looking at it is there are small defects, there are moderate defects, if you will, moderate size defects, and then of course you have the large defects. So the larger the defect, the larger will be the shunt, obviously, and therefore that needs to be closed anyway. Larger defects are normally present in the children or very young age, like in childhood, and they are presenting with left heart failure rather quickly because the left volume overload is extremely high, and the ventricle actually gets displaced more so into the left ventricular apical area, and as a result this left ventricle is huge and is failing. That needs to be repaired, and most of the time it's repaired in the pediatric cardiology practices already. Now the moderate size defects, which are commonly present and seen in the adult practices, you will see And those have moderately loud murmurs, not necessarily very loud murmurs like the small VSDs will have, but they will have moderate shunts. They'll have moderate shunts and moderately sized murmurs, and they could be present anywhere. Just remember that in the Asian population, the subpulmonic variety, which is the outlet variety, is very, very commonly seen, the subpulmonic variety. Almost 40% of these subpulmonic varieties are present in the Asian population. And the smaller the VSD, the louder is the heart murmur. Remember that. There's a small defect, and therefore increased amount of blood is flowing like across the left to right shunt, which is present here. So that smaller the VSD, smaller the ventricular septal defect, the louder is the heart murmur. Normally, these small VSDs can be left unattended. They could be just followed. They could be managed. If there's a little bit of volume overload, one can use some diuretics and help. But other than that, they are normally left to right shunts, and they've seldom reversed back into right to left. And sometimes they close, and many times they may be left alone. They're best left alone. So that was a nutshell in the VSD section today. I appreciate your interest, and thank you again for watching MuniMeterHealth.com. Stay tuned, and until then, so long. This is Dr. Sharad Jaitly from New York.